All right, looks like we're good. So just some research that I was looking into to support some isometric, eccentric, and concentric contractions. So for isometric, Muddle et al. Looked at a study at 18 resistance trained men. They found that both high torque, low torque exercise resulted in the recruitment of additional high threshold motor units in order to maintain torque production. And they found high torque exercise required the recruitment of larger motor units than did low torque exercise. No real surprise there, but the biggest takeaway I took was that submaximal and maximal isometric exercises result in motor unit recruitment. For eccentric contractions, Lee et al. 2017 looked at 34 in-season athletes with patellar tendinopathy. The main things that they were looking at were tendon stiffness and strain using a dynamometer and ultrasound. So during eccentric exercise, the cyclic loading and unloading provides a mechanical stimulus that may result in tendon remodeling, including modulation of tendon stiffness. Some of the outcomes that they found were that tendon stiffness reduced and strain increased after 12 weeks of eccentric exercise among in-season athletes, and tendon stiffness reduced by about 15%. The hypothesized mechanism of why the tendon stiffness decreased was water exudation and collagen binding. So my biggest takeaway here was increase in tendon loading during eccentric exercise. This forces the tendon to undergo structural adaptation and hypertrophic changes. So for concentric exercise, Hernandez et al. Looked at a study comparing both eccentric and concentric muscle strengthening in rotator cuff partial tears and moderate to severe shoulder pain. One group performed an eccentric exercise technique, the other group performed concentric exercise. Both showed early improvement in pain and functionality and tendon structure. However, eccentric training appears to be more effective than concentric in the early improvement of functionality, strength, and tendon healing. Why is that? It could be that we're stronger eccentrically than we are concentrically, so patients are able to tolerate that more in more acute stages of rehab. However, when it comes to returning to sport and play, concentric contractions are crucial because they're just more powerful and higher velocity movements getting towards those sport-specific movements. So, how can we apply some isometric contractions here in rehab? So let's say we have a post-op ACL, they have quadriceps atrophy, they have poor recruitment, and just trouble activating their quadriceps. So one thing that we could do early on is obviously quad sets at varying degrees of knee flexion extension to increase motor unit recruitment and gain the pathway from the CNS to the periphery to regain that voluntary quad control. Another example would be just adding overall tempos to our exercises. So I use an example again for an ACL during a step down, just performing a 3 to 5 isometric contraction. It could be in varying degrees of knee flexion extension, but what that's going to do, that's just going to recruit more motor units and create more time under tension overall for one single repetition. And then we could use a patient, let's say we have a patient who is hypermobile. We were seeing this a lot with the baseball guys. So a patient has a large amount of range of motion available, however, they are unable to, patient has a large amount of range of motion available, however, are they able to actively control these ranges and recruit the appropriate muscles through the range? So for a patient with hypermobility, performing end range isometric contractions may be beneficial in improving motor control, motor unit recruitment, and dynamic stability. So let's take an example. I know Nick and I were doing the range of motion measurements with a lot of the baseball players there, and a lot of the throwers, they would have extreme ranges of external rotation. So let's say we have a pitcher, 120 degrees of external rotation. They have a large amount of range of motion, which is great because then they could create greater torque and therefore faster pitch. However, how strong is that patient in those end ranges? Are they able to produce a maximum voluntary isometric contraction at 120 degrees rather than just a 90-degree position? So if not, things like end range liftoffs, low trap raises, prone swimmers, behind the neck PVC pipe presses, 90-90 ER with a 3 to 5 second isometric contraction at that end range could be beneficial for those patients. Just kind of strengthening towards those end ranges of motion. So We can also apply isometric contractions to gain mobility. So we know that static stretching creates a temporary perceived change in muscle length, and it's more a neural tolerance to stretching rather than actual change in muscle length. So we can use isometric contractions to gain tissue tolerance and motor unit recruitments in varying degrees of range of motion in positions where patients may lack strength, coordination, and or discomfort. So let's use a same patient. They have decreased external rotation this time, decreased lat length. We can use prone low trap raises to ingrain that flexion, missing range of motion that they may have after maybe we stretch them into that position. We can ingrain that movement pattern by doing some of those isometrics. Same thing with the ER liftoffs. And then we could use a patient with tight adductors. We were doing some of this with Ryan Wagner earlier. Like when we were doing a lateral lunge, just spending 3 to 5 seconds at those end ranges of motion. And then another one of my favorites for like tight hip flexors is a front foot elevated split squat. Front foot elevated split squat, the extremity that's in the front gets a greater degree of hip flexion range of motion, while the opposing extremity is actually getting an active hip flexor stretch because they're in a greater degree of hip extension range of motion there. And I would just spend some time in that end range position adding an isometric tempo. So in advanced stages of rehab performance, isometric contractions, let's say during plyometric exercise, patient displays an inability to land symmetrically from limb to limb, and or patient is absorbing force or decelerating at 2 different points in the range of motion. So let's say for like a single leg hop, we notice the patient's going this far, knee flexion range of motion, hopping up, but in their affected limb, they're only getting down here. So what we can do is kind of tailor it and make it specific to that patient, is just maybe perform 3-second isometric, make it symmetrical from limb to limb, and then have them perform plyometric exercise. So what that would do, it increases the motor unit recruitment in that range of motion that needs to be addressed, and it breaks up the monotony of the plyometric exercise to make it specific towards that patient. So some eccentric contraction rehab implications. Obviously, we have tendinopathies. The tendon undergoes mechanical changes during eccentric exercises. Earlier stages of rehab, we're stronger eccentrically than we are concentrically. That one study showed that we could tolerate eccentric contractions greater than concentric contractions early on. We can also use it for mobility. We know that during an eccentric contraction, our muscle is lengthening. So let's use it to our advantage. We can do a supine 90-90 overhead raise to lengthen the lats eccentrically. We can do eccentric shoulder flexion again to lengthen the lats at the cable column. That's just grabbing the cable column, starting in a more extended shoulder position, and then slowly, eccentrically, letting it pull us into that terminal flexion. And then we could also use it at 90-90 to gain more eccentric external rotation mobility. So you would start from right here, pull it into IR, and then slowly perform that eccentric contraction until we're in that more terminal external rotation range of motion. We also have lunges, prioritizing anterior tibial movement to increase the soleus mobility, something that we do here, and eccentric tempos during corrective exercises to gain mobility and a more permanent change in muscle length and tendon properties. That's basically what we're trying to do. So more advanced eccentric contractions, rehab and performance implications. So during return to play activities, plyometrics, or even strengthening exercises, where do you think your patient lies in the force velocity curve? Is your patient unable to produce force quickly? Is your patient able to produce force quickly but is unable to repeat it over time? Do they have trouble decelerating and absorbing force? So, do you notice during your plyometrics your patient has an inability or insufficiency to absorb force and decelerate their affected limb compared to their unaffected side? If so, plyometrics should be tailored to train deceleration movement patterns, and it could even program strengthening activities at an increased eccentric tempo to further address these areas of weakness. So again, if we have a patient who we notice during landing, they're landing on their unaffected limb all the way down here in knee flexion, but their affected limb is somewhere here. We can kind of tailor their strengthening rehab protocols, maybe just perform a lunge, but have them do it at a slow tempo. And then same thing for the plyometrics, we can just have them kind of exaggerate that deceleration phase of plyometrics. So concentric contractions, rehab implications. Again, where does your patient lie on the force velocity curve? Is your patient progressing through maximum strength exercises? However, during plyometric exercise presents a decreased power production from limb to limb. This is great that we now have that tool where you can actually measure that and get a value. If so, we should focus on being able to produce force quickly. So let's say we have an ACL with decreased vertical displacement during a unilateral vertical jump. How can we address this? Instead of having patients perform 3 sets of 10 to 20 reps of set exercise, we can pick 3 to 5 of the most important exercises in whatever movement patterns or muscle groups that they're particularly weak in, and we can decrease the load and just have them perform it with a more forceful intent, concentrically. This is not to say that those higher rep ranges should be completely abandoned, but I think they should be performed like later on in a treatment session. We should kind of just tailor them towards those areas of specific weakness. So some further methods of overloading concentric contractions, we can use accommodating resistance, bands, chains. I just gave a couple examples, like a banded landmine press, some banded push-ups. We can move lighter weights faster with more forceful intent. Med ball throws for core power, upper extremity power, resistance sprinting. And then we can also do reactive plyometrics, where we're minimizing ground contact time and that amortization period, which is that brief period of no movement between concentric and eccentric contractions during plyometric exercise. So basically, just limiting the amount of ground contact time that patient's foot is in contact. So this is just my personal opinion. I think that we could use tempo exercises in eccentric, isometric, and concentric contractions with all patients. I think training the 3 different muscle contractions can result in a more powerful, stronger individual. If we are training these aspects, we are training the timing, recruitment, stretch shortening cycle, and coordination to be able to produce more force overall. And essentially our muscles in conjunction with our nervous system is being trained to withstand, accelerate, and decelerate. So why do I think athletes should perform like tempos and focus some training on all different types of the muscle contractions? I think that all athletes need to be strong in all muscle contractions, because during their sport, they need to be able to accelerate, decelerate, and change directions. Therefore, they should train all types cyclically throughout the training year. And when we notice areas of weakness through movement and exercise, we need to tailor that program to that athlete in those areas that they're weak in. Why should everyday people at varying tempos should train at varying tempos? I just came up with a couple of random examples. So, like, let's say we have a 35-year-old mother, your young daughter's trying to cross the street while oncoming traffic. That mother has to quickly produce force and lunge forward to grab her daughter and pull her out of traffic. Whereas, let's say we have a 65-year-old grandmother descending steps. She misplaces one of her steps and lands on the next one. She needs to be able to eccentrically contract her quad muscles to decelerate that movement pattern, potentially prevent a fall. And then everyone in general needs to be able to grab their cups, grab their beers, drink them isometrically. But in reality, we do perform isometric contractions on a daily basis, holding a baby, carrying groceries, helping someone move furniture. So it's important to be strong overall. So if you're curious about learning more about tempos and performance, a great book I read a few years ago was Trifecta Training by Cal Dietz. He's a D1 strength coach. It's more so built, Sean and I talked about this once, it's more so built for like that top percentile athlete, but I think that there's a lot of things that he talks about in that book where you can kind of extrapolate and apply to different patient populations here. I personally ran some of his program, and one thing that I can say that I noticed during like squats and especially deadlifts, like the velocity of that was pulling the weight felt much better at the end of the program versus before. So that's what I got, boys.
So, any questions? What about like do you have any specific, like obviously you want to use all 3 different methods of like muscle contractions. Is there any time periods when you might want to like lay off certain ones and like kind of lean into other certain types of muscle contractions?
Yeah, I mean during rehab, it depends how acute like the initial stage of the injuries are, but I would say like in very acute phases, maybe performing isometric contractions, then progressing to eccentric, then progressing to concentric. That'd be like a good.
I think that's honestly like the proper order. I know Cal Dietz talks eccentric, then isometric, then concentric, but I think like isometric should come first.
Right,
Yeah.
right. I agree. Yeah, I would say that, and obviously like eccentric contractions can be very fatiguing. Same thing with long isometric contractions. So just being mindful with what the patient has going on. Like if they have games like this upcoming weekend or something like that, you maybe won't want to crush them with a ton of tempos because you don't want to send them into their sport in a fatigued state.
Yeah.
Yeah. So just kind of be mindful of that stuff. Yeah. That's what I would say. Cool. Any other questions?
That's good.
That was very good.
Good job. Excellent job.